Hello, my name is Gwendolyn Caleb. My clinical rotation site is RKM in Jackson, Louisiana. My case is a 62-year-old African-American male, Mr. HC. His date of birth is 9/21/1958. He presents to the clinic with his sister. His sister appears to be a reliable historian, and he seems to withhold information. Mr. HC's chief complaint is coming to the clinic for lab results. He complains of shortness of breath upon minimal exertion and when lying down. He also complains of feelings of weakness and fatigue, swollen extremities for the last 2 weeks. What makes things worse is when he lies flat. What makes things better is when he's sleeping in an upright position or when he puts multiple pillows under his bed during sleep time. His primary medical history is GERD, hypertension, chronic kidney disease, COPD, and he has a history of a GI bleed times 1 month ago. His surgeries: he's had multiple surgeries to his right arm, January 2001. He is allergic to penicillin, in which it causes a skin rash. He refuses the influenza and the COVID vaccination. His family history: his mother deceased age 78 due to leukemia. His father 62 deceased due to lung cancer, and he had a history of hypertension. A maternal aunt deceased at age 61 due to brain cancer. His social history: widowed times 12 years, no children. He lives with his sister in a 2-bedroom apartment. He is disabled. He drinks 4 beers daily over the weekend. He's a former smoker, in which he stopped in 2006. He drinks 1 to 2 cups of coffee daily, no illicit drugs. He has a 10th grade education, no past occurring arrest or incarceration. He does not participate in an exercise regimen. His review of systems is unremarkable, except for the respiratory, the cardiovascular, and the musculoskeletal system. Constitutional-wise, Mr. HC denies fever, chills, and significant weight loss. He does complain of fatigue and a weight gain of 5 pounds over the last couple of weeks. Respiratory-wise, he complains of shortness of breath upon minimal exertion. He complains of some wheezing, some coughing with some nasal drainage, which is clear. Cardiovascular-wise, he does complain of some edema to his bilateral lower extremities. In the musculoskeletal system, he does complain of a little joint stiffness, weakness, and decreased range of motion due to the edema to the bilateral lower extremities. Objective-wise, his vital signs: blood pressure 168/91, in which he forgot to take his antihypertensive this morning. Heart rate 70, respirations 20, temp 98.1. He sat 94% on room air. He complains of no pain at this time. He's 5'9". He weighs 144.8 ounces. His BMI 21.34. He had labs drawn the beginning of May, in which his renal studies were really abnormal and high. His most recent labs were May the 14th. His WBC count was 9.5, RBCs 3.96, hematocrit 36.5, hemoglobin 11.7, neutros 68, platelets 280, sodium 143, potassium 5.2, chloride 111, bicarb 36, BUN 80, creatinine 4.27, BNP of 347, which is the indicator of congestive heart failure. Objective: Mr. HC is an elderly man with a slim-built body. He's dressed appropriately for the weather. He's unable to maintain eye contact, and he appears to be a little worried. His respiratory system: there is some wheezing noted to the lower lungs, both anteriorly and posteriorly. He's using some accessory muscles, and there is some shortness of breath that is noted. And cardiovascular-wise, there is some +2 pitting edema to the bilateral lower extremities. And his assessment: Mr. 62-year-old male, Mr. HC, with the history of GERD, kidney disease, hypertension, COPD, and arthritis, with the complaint of shortness of breath upon minimal exertion, fatigue, cough, and swollen bilateral extremities. His differential diagnosis is acute exacerbation of the COPD, and according to Harvard, some of the symptoms may include green or yellow sputum, difficulty breathing, and some wheezing. Pulmonary embolism: according to Howard, one may experience shortness of breath, hypoxia, syncope, fever, wheezing, productive cough, decreased level of consciousness, spitting up blood, and flank pain. Congestive heart failure: according to Pappas, one may experience difficulty breathing, weakness, edema to bilateral extremities, rapid heartbeat, persistent cough, or wheezing. I'm going to use congestive heart failure as his diagnosis, and it is supportive of his symptoms, which include shortness of breath upon minimal exertion and when lying down. He is wheezing, and there is some coughing that is noted with some clear drainage to the nose and some bilateral lower extremity edema, which is +2 pitting. The plan of care is to continue his current medications, call in his inhaler refills, do an in-house EKG, in-house labs to include a CMP, CBC, BMP, and do a chest x-ray. I'm going to refer him to cardiologists, nephrologists, and gastroenterologists. It's because he had a GI bleed times 1 month ago. He did not follow up with that appointment with the nephrologist. He's not following up like he should. With the cardiologist, I am referring him there because his case is rather complicated, and this is what makes it challenging because he has a lot of abnormal kidney functions going on with the history of chronic kidney disease, in which he needs a diuretic to get rid of some of the fluid. But at this time, I don't feel comfortable in prescribing a diuretic. And I'm using the problem solving for decision making by Watson because, again, I'm going to refer him to the cardiologist to follow up. I'm going to teach him to decrease his fluid intake to maybe 1 to 2 liters of fluid a day, to minimize his alcohol intake, to limit his salt intake to 2 to 3 grams a day. And instead of using salt to his food, he can use herbs. I would also have him to develop an exercise regimen. And I would like for him to return to the clinic to seek emergency services if symptoms worsens. If not, he can return to the clinic in 2 weeks for evaluation. And I'm using the holistic approach by looking at the emotional, the mental, and the physical status of the patient. This concludes my video.